afternoon, everyone. Again, with Dr. Bachir Taouli, we're going to start the questions, and I have a question from Pradnya Mahitar. Pradnya.
Thank you, Dr. Taouli, for a great lecture. I just had a couple of questions. The data you showed for the dynamic MR abbreviated study, is it with EOVIST or was it with extracellular agent like multi-hands?
The data from our center was with EOBD-TPA, with EOVIST.
Okay, do we have any data for multi-hands in any of the studies, or everything has been done with EOVIST?
I think the data published is a couple of papers. They used an extracellular agent. I do not think there is any use of multi-hands published.
Okay. And my second question was, I know you have kind of extrapolated the data from the entire MR studies to get the sensitivity and specificity. Are you guys in real life doing abbreviated MRI for surveillance? And if you are you coding and billing is at a separate abbreviated MRI? Or I guess that's the second part of the question, or you're doing coding and billing it as like the entire abdominal MR?
So in my experience, actually, so we've been doing actually a prospective study, research study for the last 2 years on abbreviated MRI with EOBD-TPA compared to ultrasound the same day. And we have done over, I think, 50 or 70 cases actually total. This is really built to a research study. We're not billing it clinically yet, but I know other institutions like UC San Diego have been billing this to insurance as a limited MRI, but we do not do this yet because we want to wait for kind of meaningful results before we start billing it clinically.
So, well, if I get it right, it's because this has been getting attention for like a couple of years now. So right now I work in a smaller hospital. It's not a research institution. So but we do have patients, it would be much more beneficial for them to have a shorter time duration MRI. But there is really no for private practice kind of precedence as to doing this with the abbreviated MRI. That's still not being done countrywide.
Yeah, I think we need to wait for more meaningful data because currently all the data, like I showed, was reconstructed, so it's kind of virtual in a way. Abbreviated MRI, we need really real data, meaning real abbreviated MRI, either alone or compared with ultrasound. We need to see what are the limitations, what is the recall rate, so there's a lot of complexity around it. I mean, it seems to be easy to do, but there's the whole context that has to be taken into account, meaning, acceptance. I mean, I had, for instance, some clinicians resisting the idea of having a limited study while they say, if the patient is coming anyway, why can't you just do a full one? So there's a whole conversation to have. And in order to have a good conversation, you need to have good data.
Okay. I guess within a similar note, it's great if patient can actually complete the entire MRI examination, but sometimes even in the beginning, this is not going to go well, and you want to get this patient may be able to be in the scanner for 15 minutes or 20 minutes maximum, and is it okay or is it acceptable to do an abbreviated protocol knowing that you're not going to get the entire study and then apply LI-RADS to it? And this I mean by actually getting the dynamic sequence, at least not just the hepatobiliary phase after or something. Is it okay to put LI-RADS in and get a LI-RADS category if you think the study is adequate? Like you have your key components.
Yeah, I think overall most of the LI-RADS, lexicon is based on dynamic imaging, right? But if you just do dynamic T1 for HCC diagnosis, I think it's totally okay. Not totally, I would say I think it's okay. However, you'd be missing some ancillary features. So you have to remember that, like ancillary features on diffusion or on the delayed hepatomegaly phase. So you'd be kind of limiting yourself only to dynamic imaging, which is most of the time okay, but that additional percentage of cases where you may diagnose a LI-RADS 4, for instance, would be missed. So yeah. But I'm really talking only about screening here. So for diagnosis, it's really a different story.
Okay. All right. Thank you very much.
Great. Thank you very much, Dr. Pradnya Mahitar. I want to introduce also Thana Rabi. She has a question or a question, yes. Thana.
Assalamu alaikum.
Salam.
Thanks first for this astonishing lecture. It is very informative. But we had 2 lectures concerning ultrasound and contrast enhanced ultrasound, which displays very informative images and results. We were astonished to the degree we thought that we can replace CT and the MRI with contrast enhanced ultrasound in some cases. My concern here, did these studies compare the MRI to ultrasound done by expert radiologists and after using contrast enhanced ultrasound, or what?
I don't think there is any comparison with, first of all, there's very little data on contrast enhanced ultrasound in HCC screening. I mean, I don't think there's a lot of data because look, I'm not an expert on CE ultrasound, but I think CE ultrasound is used typically for characterization of nodules that you detect on BMOD ultrasound. So if you see something, you characterize it, but it seems to be more challenging to use it for just screening for the whole liver when you inject. I mean, you could do it, but I don't think there's a lot of data out there.
Okay.
I think using the contrast enhanced ultrasound may increase the specificity and sensitivity of ultrasound.
For characterization, yes, but for screening, I don't think there's a lot of data. Meaning screening for any lesion in the cirrhotic liver, I don't think there's meaningful data out there.
Thanks.
Thank you. Thanks, Sana. Raj Hilavar from India. Raj, do you want to give your question?
Hi, Dr. Taouli. Thank you for a very beautiful lecture. So we've heard about synthetic MRI in the brain, where a short acquisition can lead to multiple sequence generation. Is there any similar progress on abdominal image acquisition, which could reduce the time of acquisition? Thank you.
That's a very, very good question. So I think you're probably referring also to fingerprinting. Fingerprinting is really very promising. However, it's still a work in progress. It's been used a lot in the brain, a little bit in the prostate. There's a lot of quantification, of T1, T2, and eventually diffusion, but it's not, to my knowledge, being applied in the liver. It's much more challenging in the liver because of respiration, the complex anatomy, etc. But that would be really something really interesting to think about. And then there's also synthetic images, which is calculated images, for instance, in diffusion. But my experience has been quite, disappointing with diffusion, for instance, looking at higher B values. We didn't find it to be really that useful clinically, but that's my own experience.
Thank you very much.
Thank you very much, Raj. Claude, I think Bachir mentioned you during the lecture in one of your papers. So do you want to make any comment or have any question?
Yes, thank you. First of all, Bachir, thank you for that absolutely fantastic and very clear lecture. Can you guys hear me right now?
Yes, we can hear you.
Oh, great. So one of our ex-residents who's now a faculty at Stanford, his name is Ryan Brunsing. He did recently publish a paper in one of the radiology journals. I think it might have been Radiology Oncology or something like that, in which he summarized our real-world experience using abbreviated MRI. So not a simulated MRI protocol, but a real abbreviated MRI protocol in HCC surveillance. And in his analysis of the first couple years in which we were doing it at UCSD, he found that the per patient sensitivity was on the order of 80 to 90%. More recently, Anna Pecorelli, who from Italy, she visited San Diego for 6 months, and it's going to be presenting at ESCAR, virtual ESCAR, I think in a couple weeks, summarizing an update on that data. And she looked at the first 600 patients that we performed the abbreviated MRI protocol for clinically. So again, this is now clinical abbreviated MRI, not a simulated MRI, not a research MRI, but a clinical abbreviated MRI in patients under surveillance. And in the first 600 patients, she found that abbreviated MRI has a sensitivity of 85%. So it's not 100%, but it's considerably better than the historically reported ultrasound. Something else that I think could be mentioned from a radiologist perspective is that the interpretation of the abbreviated MRI is very, very easy. So when you're having a busy clinical day and you have a lot of CT scans and a lot of MRIs and they're complicated and they're time consuming, and then suddenly you get an abbreviated MRI to review, it's an unbelievable relief because it's so easy to review them. It takes about a minute to review them. Now at UCSD, the way we do this is we charge a limited exam modifier. I don't know that that's the right thing to do. I think the research that Dr. Taouli is doing is going to be very, very informative to figure out what is the cost effectiveness of AMRI and maybe come up with a price that actually makes sense. So what we have done is we've charged 50% of a regular MRI. The 50% was arbitrary. We didn't do any research to show that 50% was the right amount, but that's what we do. So we charge insurance companies 50% of what we normally charge for an MRI. And the MRI is shorter for the patient, and for the radiologist, it's a lot easier to read and interpret. So we've been quite happy with it at UC San Diego. There are some challenges, that some insurance companies will not reimburse, and so therefore the patients will have to have some other sort of surveillance, but our initial experience has been quite positive. And I guess I'll just stop now. I just wanted to say again to you, Bachir, I thought you gave a great lecture, and look forward to more data coming from your group, in the years to come.
Oh, thank you, Claude. I just want to actually, echo to what you said in terms of, easiness of interpretation. That's clearly the case. And we had also a few patients where we did a questionnaire, but we asked them, and they really liked the idea of being in and out quickly. So that's really clearly two advantages. I just want to mention for pricing, this is a complicated issue, and insurance. So I just want to mention also that a lot of my colleagues in hepatology are complaining that they're having hard time more and more with insurances to get approval for a full MRI for screening. I mean, this has been the case for they've been doing it forever now on Mount Sinai, but now they're getting a lot of pushback on insurance to say, why are you doing MRI? Why don't you just do an ultrasound? So I think if we were to push a lighter version of MRI as an effective tool and remove the ultrasound in at least some cases, I think insurances would be appreciative of that. But I think pricing is going to be something we need to discuss, because even if you cut it in half the time, the contrast is not cut in half. So that contrast actually is expensive. You're still having $140 for a vial. That's not going to be cut in half. So it is a complicated, equation. And one of my residents actually is presenting an ACR poster next week to talk about costs, and she's been actually doing very complicated, simulations to look at what's the ideal cost, and it's not simple.
Okay, thank you all. We have a question from Reem Al-Bahrani. She's asking me to give the question. Reem, you don't want to give the question yourself? Oh, she has a noisy background. Okay. So her question is, her kids are around. What's the frequency of doing completed MR protocols for further characterization of observations detected on screening MR?
Okay, so let me repeat the question. So what is the frequency of doing the recall full MRI, correct? Yeah.
Yes.
So when you do a real screening population, you expect the incidence prevalence of HCC to be small, right? It should be between 1% and 5%. Best case scenario is going to be 5. In our experience, it's been more about 5%. So that means if you do 100 cases, you're going to have 5% of real HCCs that need to be recalled, like of lesions. But in addition, you need to factor in false positives, and false positives will be about 5%. So if you add up the two, you come to about 10%. So that means if you have 100 cases of abbreviated MRI with EOB, you're going to have 10 cases that needs to be recalled. Out of those 10, 5 are real HCCs and 5 would be other lesions. I hope that answers the question. Approximately.
Yes, yes. Okay, thank you very much, Claude. Yes, she's saying yep, thanks. And I don't have any further questions. I mean, this lecture was really clear, and it's about a very important topic, and we appreciate your being here, Bachir, and giving this very clear lecture. Thank you, everyone who attended, and the ones who give questions, and we look forward to seeing you again. Tomorrow we have also an exciting lecture from my colleague and a friend at MD Anderson, Janu Skorluk. He's going to talk about MR technique related pitfalls. So I'll see you tomorrow. Grazie, Roberto, and Buonasera, Georgia, and Federica. And I will see you tomorrow, hopefully at the same time. Thank you very much. Appreciate it.
Thank you, Khaled. Thank you, everybody.